Thanks for having me back to talk about stones or nephrolithiasis. I like seeing patients with stones because it's kind of nice change of pace from the CKD patients, advanced CKD patients, because typically the patients with stones have normal kidney function. So it's refreshing to see those folks once in a while. Okay. Okay, so I'm going to talk about the clinical significance of stones, epidemiology, and then I didn't think I could do a talk for you guys without talking about, the management of symptomatic stones. So I am going to talk about that, but I don't want to spend too much time on that because, that's really, urology, the urologist's purview, and so I'm not the expert necessarily in this area. But what I am, what I do on a regular basis is try to prevent stones from forming in people who've had stones before. And so that's what I'm going to focus most of my time on. So stones accounts for over 1 million visits to the ED annually in the US, and also over 40,000 surgical interventions. Annual costs dealing with stones add up to, close to $5 billion as of when this paper was written, so could be exceeding $5 billion by now. As you know, it's associated with significant morbidity, renal colic, sepsis. Patients can die from obstructed infected stones. So this is from one of my former patients. So we used to get tons of stones, and he would just sort of keep a log of the stones, and I always kind of laughed but kind of grimaced seeing him, write down that he had, 7 out of 10 penis pain that day in that July. The prevalence of stones in the United States is increasing. It was about 5% in 1994, close to 10% in 2012. I'm sure it's higher than that now. Up to 60% of men and 8% of women in the United States will have 1 or more symptomatic stones by age 70. And it used to be that it is more common. Stones are more common in men, but the ratio is changing. So it used to be 3 to 1 in favor of men to women, but now it's more like 2 to 1. And then a recent study showed that there was no difference in prevalence by gender in younger adults. And so presumably this is due to lifestyle changes, namely obesity. And so you may know that the prevalence of stones varies by geography. So it increased from north to south, west to east. So, the Carolinas, Georgia, Alabama, Mississippi, Tennessee, they're part of the stone belt. And so the prevalence of stones is up to 50% higher in the southeast than the northwest. And it's thought that the higher temperatures in the south accounts for most of this variability. And the rest would be other risk factors. And so it's interesting. So this map shows, the yellow shows sort of the current, stone belt, mainly the southeast, parts of California. But in this paper, the authors, took the climate changes sort of, predicted in the next, several decades, and then applied that, to changing risk of, of stones. And you can see that by 2050, that, the stone belt, is probably going to expand, further north as temperatures increase. So I just want to talk quickly about, the management of acute, or the presentation of acute stone episode. So the most common symptoms, flank pain, nausea, vomiting, hematuria. And so the pain results, so when you have a stone that's causing obstruction, you have increased intraluminal pressure, hydronephrosis, and then the sort of the tension, stimulates the nerves in the urothelium. And that causes pain in and of itself, but also, triggers prostaglandin release, and that causes, further spasms and, and additional pain. And so typically, we think of it as, starting as a waxing and waning. It's possible that, if the pain is constant, maybe it indicates a more severe obstruction versus if it's intermittent, it may indicate an incomplete obstruction. So the pain, can be located, anywhere in the, abdomen and the GU tract. So, patients may report having pain in the, in the abdomen or the groin, the bladders, genitals, depending on where the stone may be in the urinary tract. And typically it's described, that patients with, who have renal colic, they're unable to find a comfortable position. So they're riding around trying to find a comfortable position, but they just can't. And nausea, vomiting may occur in up to 50% of patients who have it. This results from stimulation of the celiac axis and vagal nerve afferents. And then hematuria is very common, but usually it's microscopic hematuria, not gross hematuria. And this results from injury to the ureteral and bladder wall. It's most common on the first day of symptoms. And actually, so it's most common in the first day of symptoms. And as days progress, you have hematuria less frequently. So while having hematuria is suggestive of stones, doesn't mean if an individual doesn't have hematuria, doesn't mean that they don't have stones. And then patients can also have UTI-like symptoms, especially if the stones are in the bladder, and the bladder walls being irritated, may manifest as urgency, dysuria, frequency, pain, urethral meatus. And so chills and rigors are usually not present, right? So if those are present, you worry about infected stone. An infected stone is a urologic emergency. On exam, if patients, if they're having a lot of pain, you're not going to be surprised to see tachycardia and hypertension. CVA tenderness present in maybe, up to 50%. Here's a reminder of where the costal-vertebral angle is. The abdomen should, is usually soft, but, in some cases, patients may, have guarding, rebound tenderness. Again, fever, hypotension are rare, right? Of course, that should prompt you to look for associated UTI, abscess, sepsis. Again, infected stone is an emergency. Of course, looking at labs, I'm going to be wondering about the kidney function. So you may see only a slight increase in creatinine when you have a unilateral obstruction. Patients could have, if they're having nausea, vomiting, they're not, not taking PO, they may have, pre-renal AKI. You're more likely to see significant worsening kidney function in patients with, if you have baseline CKD, or of course, if a patient only has one kidney, or an infective, maybe they have two kidneys, but one's not functional, and that, the sole functioning kidney is obstructed, that's going to certainly cause significant kidney injury. On the CBC, you may see some leukocytosis, and maybe a sign of infection, but it could just be a stress reaction. And of course, you're going to be getting urinalysis, and you're going to be looking for hematuria and pyuria. And on imaging, so in the acute setting, when someone's complaining of flank pain, you're worried about a symptomatic stone. The gold standard for imaging is a non-contrast CT, so a stone protocol CT. And this is actually a patient of mine. He's, I think, a 50-some-year-old gentleman. He has a history of stones requiring urologic procedures to remove them, in the past at a different hospital. And then he presented to me because he had a history of stones. And I think he'd gone to the ED for some other issue like back pain. And then he'd gotten a scan and, found to have multiple stones, referred to me. So I saw him, but then after that, he ended up having some right-sided flank pain and some hematuria. So he ended up seeing urology. Urology ordered a CT scan. And so I'm not a radiologist, but this is the right kidney. This is the left kidney. You can see that this one looks abnormal. So that you can see the hydronephrosis, that there's obstruction. So if you scroll down further, you can. So this is the stone that's in the ureter that's causing the obstruction. And then if you look at coronal planes, you see the hydronephrosis, but you also see that he has the kidney on the other side as well. So, okay, so how are you going to manage these folks? Maybe, we're all internal medicine, but, you all have to do rotation in the ED. So first, pain management. So as a nephrologist, I don't often say, use NSAIDs, but in this case, given that we know that there's prostaglandins being produced by the urothelium in the setting of obstruction, then it makes, mechanistically, it makes sense to use NSAIDs. And then opioids, for if NSAIDs alone are insufficient or if there's contraindication to using NSAIDs. And then I'm sure you all are aware of using, alpha blockers, and they have been studied, and there is data showing that use of alpha blockers results in a higher rate of stone passage, quicker time to stone passage, decreased analgesia requirement, and lower hospitalization rates. And of course, I think we all think about using IV fluids. So typically, I think we think of, we tell patients, drink a lot of water to help, flush out the stones. It's actually not the case. So there actually isn't data. So the data doesn't show that giving IV fluids, helps with stone passage. And so typically, we'd use in patients, who are, nausea, vomiting, and who appear volume depleted. And so So some stones are going to, are going to pass spontaneous. Actually, I should say many stones are going to pass spontaneously. Whether or not a stone passes, is dependent on the size of the stone and its location. So you can see from this table. So as the stone size increases, the spontaneous passage rate, decreases. But even fairly sizable stones, in the 7, 8, 9 millimeter range, can pass. And then again, in terms of location, so stones that are more proximal are less likely to pass. So proximal ureter, 48% passage rate, mid-ureter, 60%, distal ureter, 75%, stones in the ureterovesicular junction, 79%. Okay, so if you have a patient who looks non-toxic, uncomplicated stone disease, those can be managed as an outpatient, or if they're in the ED, they can be discharged, or if they're calling you, in an urgent setting. You can give them, an alpha blocker, and you can manage them as an outpatient. After one episode of a symptomatic stone, so a patient calls you and says, "Okay, doc, I peed out a stone. What do I do?" If they're, if the pain is gone, they probably don't need a further evaluation. But of course, if someone's, in the ED, or someone, has a very large stone, or recurrent stones, then they're going to need closer follow-up. They're going to need to see urology. And of course, if patients have any of these characteristics, intractable pain, vomiting, sepsis, an obstructed single or transplant kidney, significant acute kidney injury, or history of urologic procedures, these are the folks that are probably going to get admitted, and you're probably going to ask urology to see. And so again, I'm not a urologist, so I'm not an expert in these procedures, but I'll just tell you what, what my patient got. So he underwent laser lithotripsy. And so this is not his photos from his picture, but just from a paper. But so the urologist did a ureteroscopy, right? So they put a camera up into the ureter, and then they use a laser, I think it's holmium, and then they laser the stones, break it up, and then they use a basket to remove all the pieces. And so typically, if the stones are very large, or refractory to medical therapy, that's when patients would need some sort of surgical intervention, as deemed appropriate by urology. And so usually, the urologists, when they're blasting these stones and removing them, they will send some to the lab to analyze the stone. If you see a patient and they haven't passed the stone yet, but they look good, you're going to manage an outpatient. We encourage patients to strain their urine and catch any stones, and then bring them into the lab. So apparently for 42 cents, you can get a urine strainer. And so this is an example. So my patient, he underwent the lithotripsy. The urologist sent some samples to the lab for analysis. And so you can see that, so his stones were 20% calcium oxalate monohydrate and 80% hydroxyapatite, which is a form of calcium phosphate. And they also, the report also included, these photos of the stone particles. Okay, so why do we care? So why do I want to know? Why do we want to know what the stone is made of? Well, it's because stones, they can recur, and the recurrence risk is fairly high. So patients who pass a first kidney stone have a 15% risk of developing a second stone within a year, and nearly 50% risk within 10 years. And stones can be prevented with the management of modifiable risk factors. So what are some of these risk factors? Obesity, low fluid intake, low calcium intake, low potassium intake, high animal protein intake, high salt intake, hyperoxaluria, and then certain medications. And so this is where I come in. So recently, actually, I don't know when the episode of Jeopardy was, but this is posted on Twitter, tweeted by a urology resident. But so, the answer is, repeat kidney stones probably call for a visit to this type of kidney doctor. And the correct question was, who is a nephrologist? So much to the dismay of the urology resident, he was kind of screaming at the screen. But so I will mention that urologists also are involved and manage risk factors as well. And so let's talk about the types of stones. So this pie chart indicates the composition of first-time stones versus recurrent stones. So you can see that the most common type of stone is calcium oxalate. The next common is calcium phosphate. But together, calcium-containing stones account for the vast majority of stones. And then in terms of recurrent disease, you have a little bit more, higher percent of calcium phosphate, higher proportion of uric acid, higher proportion of cysteine. There's slightly lower prevalence of calcium oxalate stones. But again, they're the most common by far. And so let's talk about the calcium oxalate stones. So you guys, I'm sure you guys remember, well, you guys are going to be tested probably on these crystals. So calcium oxalate monohydrate, have the dumbbell shaped, and the stones typically, or the most common type of calcium oxalate monohydrate stones are dark color like this. There are I think 4 or 5 different types of calcium oxalate monohydrate, but these are the most common. And then calcium oxalate dihydrate, form the envelope-shaped crystals, and the stones, well, the most commonly seen stones kind of look like this, although depending on the etiology of calcium oxalate dihydrates, they can slightly vary in morphology. Okay, so risk factors. So, low urine volume, typically, less than 1 liter a day. And I think this is, easy to understand. So the less urine volume, the lower your urine volume, the higher, concentration of solutes, of calcium oxalates, right? So they're more likely to be, to reach the point of solubility and actually reach supersaturation, which, leads to crystal formation. High, urine calcium levels, defined as maybe, 250 milligrams per day in women, 300 milligrams per day in men. Most of the time, we can't find a cause. They're idiopathic. But, we do look for things like primary hyperparathyroidism, excess vitamin D use, and then, distal RTA, and then, sarcoid malignancy, Cushing's, may also be associated with high hypercalciuria. Of course, the stones are made of calcium and oxalate, so high oxalate levels in urine are also going to be a risk factor. So typically, we're aiming for urine oxalate less than 40 milligrams a day. So if it's higher than that, we would say patient has hyperoxaluria. So how does one develop hyperoxaluria? So one cause is high dietary oxalate. So things like spinach, rhubarb, chocolate, iced tea. Those are some foods and beverages high in oxalate, but also vitamin C. So vitamin C is metabolized to oxalate. So if you have patients taking mega doses of vitamin C, not sort of routine doses, regular doses, but mega doses of vitamin C may increase urine oxalate levels. And then fat malabsorptions. So any condition where you're going to have diarrhea, fatty stools like gastric bypass, inflammatory bowel disease, pancreatic insufficiency, cystic fibrosis, you're going to have higher oxalate in the urine. And so this is probably a commonly tested concept. So this is enteric hyperoxaluria. So you have so typically in the gut, calcium is bound to oxalate, forming calcium oxalate. This is not absorbed. But in the setting of malabsorption, where you have high levels of fat, what happens is the calcium. So you have calcium oxalate and free fatty acids, and the free fatty acids end up binding to calcium, and then releasing the oxalate. So you have calcium bound to fatty acids, and the oxalate is by itself able to be absorbed. And then you also have decreased bile acid reabsorption, and then which increases the permeability of oxalate in the gut. So you have a couple different factors increasing oxalate absorption. And then also another cause, a rare cause of hyperoxaluria, primary hyperoxalurias. There are 3 types. These are inborn errors of glycoxylate metabolism, and these are autosomal recessive conditions characterized by oxalate overproduction by the liver. So manifesting as recurrent kidney stones, nephrocalcinosis, end-stage kidney disease. And so what happens is, so you have high urine oxalate levels because the kidneys are filtering the oxalate, and then and as the patients develop CKD and the GFR goes down, once patients are CKD 4 or worse, then you have very high levels of oxalate in the circulation, and that can lead to oxalate deficits in other organs like the heart, bone, retina, and the skin. And so this can actually be cured with a liver and kidney transplant. But before someone gets to that point, we we try to reduce oxalate production with pyridoxine, which is vitamin B6. And then there's a new drug that's, I think was just approved, I think at the end of last year, lumasiran, which is a small interfering RNA that blocks transcription of one of the enzymes sort of in this, in this pathway, which results in reduction of oxalate production by the liver. So this is just a graphic from the New England Journal article, right? So if you have, so in the person whose kidney function is still okay, you have, lots of oxalate stones forming in the kidneys. You might see oxalate crystals in the urine. And then as the kidney function gets worse, because you have more and more calcium deposition in the kidney, you may see nephrocalcinosis, which is the calcification of the renal parenchyma, typically in the medulla. And then, because the kidney, you have such reduced excretion of oxalate, you're having high systemic levels of oxalate, and you're having oxalate deposition in other tissues, bone, heart tissues. And then once, patients ends up on dialysis, and then, this is just that you can see calcium oxalate crystals in the bone. But that's where I actually haven't seen a patient, managed a patient with this condition. Okay, and then the last thing we'll talk about is hypocitraturia, so low citrate levels. So maybe it's kind of variably defined depending on where you look, but maybe less than 300 to 500 milligrams per day. So why is citrate important? So citrate in the urine forms soluble complexes with calcium and reduces calcium supersaturation. So basically, when calcium binds to citrate, it's soluble. That complex is soluble, whereas calcium binding to oxalate is not soluble. So basically, citrate binds calcium, so there's less free calcium available to bind to oxalate. And so this can occur in the setting of metabolic acidosis. So in the setting of acidosis, citrate is used up as a source of bicarbonate, so there's less citrate available to bind to the free calcium. So that you can might see that in setting of diarrhea or high protein intake, RTA, Topamax, so topiramate. I think it's a medication that's used pretty commonly for migraine prophylaxis or other reasons. And so you can see an RTA from topiramate. Okay. So, so we talked about, these risk factors like hypocitraturia, hypercalciuria, hyperoxaluria. So how do we know if a patient, has any of these risk factors? So there are, so this company called Lithlink is what typically most people use, and they offer a 24-hour urine test to measure all of these things. And so this is what they look like. So you send, you fill out a request. The company will send, a kit with instructions to the patient. The patient will collect their urine and then send it back, and then you'll get a report that looks, well, it's a several-page report, but this is sort of the key table, and you can see that, they measure the urine volume, they measure the supersaturation of calcium oxalate, urine calcium, urine oxalate, urine citrate, supersaturated calcium phosphate, what's the pH, what's the supersaturation of uric acid, what's the, the total urine uric acid. And so you can see it, and they, if you have the color version, you can see that, you can see how your patient's doing on the spectrum of, good to bad in each of these areas. Although, so I like seeing these, the ones where there's lots of areas to work on, because so the risk, even if a profile looks bad, patients may not have any stones. And then I have patients who, this one actually, in the lower right, so this person actually, of all these patients, this person probably has the worst, stone burden and most stones. And it's kind of frustrating for me because I feel like the risk factors are well controlled and she's still having lots of stones. Where I can't remember which one of these guys is not having, not having any stones. So it's very, it's very individual. And a good profile doesn't necessarily mean, fewer stones. So you just have to, look at the individual and compare the individual, to themselves. But you get a sense of what they look like. Okay. So, all right. So we've been talking about calcium oxalate stones and the risk factors. So how can we prevent calcium oxalate stones? So I think the first thing is, increasing the urine volume, which is, which is true, holds true for any stone type, right? So, right, the more volume, right, the lower saturation of calcium and oxalate, less likely to form crystals. And so the guidelines recommend aiming for a urine volume of 2.5 liters a day or more, which is challenging. A lot of my patients are motivated. I think you can go back and see that, 2.7, 5 liters, 4 liters, 3 liters. So a lot of patients, can do it. They're motivated, but for other patients, it can be challenging. And then you want to reduce the urinary calcium with low sodium. So if the urine calcium is high or on the high side, you want to try to reduce that. The first thing you can do to reduce urinary calcium is to eat a low sodium diet. So how does that work? So if you recall, so calcium reabsorption is the proximal tubule parallel sodium reabsorption. So the more sodium is reabsorbed proximally, the more calcium is reabsorbed. So what are the situations where more sodium is absorbed, proximally? Well, it's when you have, low sodium intake, or your volume depleted. And so if your sodium intake is high, right, there's going to be less sodium reabsorption in proximal tubule, so less calcium is going to be reabsorbed, more calcium in the urine. Okay, so low sodium diet reduces urinary calcium. Oh, and here's an article. So you can see that, so the higher the urine sodium excretion, aka sodium intake, the higher the urine calcium. So that correlates nicely. Okay. Another way to reduce urinary calcium is to follow out, reduce animal protein intake. So high protein intake, proteins, contain lots of acids. So if your protein intake is high, your acid intake is going to be higher, higher than if you have a lower protein intake. And so when you have acidosis or high acid intake, that acid is buffered by, resorption of bones. So when, the bone is resorbed to, buffer this acid, calcium is released, leads to to higher levels of urinary calcium. And so this is a chart. So on the bottom, so urine nitrogen grams per hour. So this is, increasing protein intake versus, urine calcium. So you can see, so it's interesting. So in women without stones, so higher urine nitrogen does lead to urine calcium, but not a whole lot. But in women with stones, you can see that increase in protein intake leads to a significant increase in urinary calcium. And the same thing in men, right? If you don't have stones, yes, higher protein intake, higher urine nitrogen will lead to higher urine calcium, but it's not as drastic as in patients who form stones. Okay, and then if of course, we start with dietary interventions first. But if if patient's urinary calcium is still high despite limiting salt, and limiting animal protein intake, then you can add a thiazide. So thiazides cause a little bit of volume depletion, right, which increases sodium and calcium reabsorption proximally. And this is from a meta-analysis of studies that have looked at thiazides, including HCTZ, chlorthalidone, and dapamide, and the meta-analysis shows that there is a benefit in using thiazide diuretics in preventing stones, reducing the risk of stones compared to placebo. Okay, so sometimes. So if you think, if you're worried about calcium oxalate stones, then, sometimes people think, oh, then I should probably, consume less calcium. And that's actually not the case. So calcium is important, actually, because, it binds to oxalate in the intestine and prevents absorption of oxalate. So you can see that, from a study where individuals were on a normal calcium, low protein, low salt diet versus low calcium diet. So they basically restricted dairy intake, and you can see that over time, the low calcium group had a higher risk of stones. So certainly, I tell patients not to restrict their dietary calcium. We aim for 800 to 1,000 milligrams a day. Although I encourage them that, if you're going to eat something with high calcium, like a yogurt or ice cream or something like that, sort of eat it with other food so that the calcium that you are ingesting, is available to bind oxalate. Okay. And if your patient, if the lip filling shows high levels of urinary oxalate, then you counsel patients to reduce dietary oxalate intake. So I think I mentioned before, spinach, rhubarb, they're very, very high in oxalate. Although all these other things, on here are considered very high as well. And this is from a Harvard, I think maybe school public health website or something that's, it's literally an Excel spreadsheet with, thousands of entries so that, so you can go and search for, for foods that, you want to know what the oxalate content is. Okay. And so you also can try to reduce urinary oxalate excretion, right? So you can try to minimize oxalate intake, but you can also try to reduce urinary oxalate excretion, right? So by adding calcium supplements with meals, again, to bind the oxalate. And then also sometimes, folks have tried cholestyramine to bind the fatty acids and the oxalate, although there's no, randomized control trials. Okay, the other risk factor is low urinary citrate or hypocitraturia. So if your patient has that, then you want to increase the urinary citrate, so you can give citrate in the form of potassium citrate, although it can cause pretty severe side effects, GI side effects in some patients. So you kind of start low and go up. Lemonade contains a lot of citric acid, as does orange juice. Orange juice contains calcium citrate. And then there are several diet sodas that contain citrate as well, although I haven't had any takers. I haven't had any patients who are interested in drinking lots of Fresca and other these diet sodas. But I do always have a chart that I keep in my pocket, in case I meet someone who with hypocitraturia who really likes drinking diet soda. Okay, so that's calcium oxalate stones, and we're going to spend the most time on that because that's the most common form of stone. And then the other calcium stone is calcium phosphate stones. The crystals will be, sort of flat or wedge-shaped prisms, and these are some, examples of calcium stones on the right, or calcium phosphate stones on the right, excuse me. Risk factors, again, same, some are going to overlap with calcium oxalate, like low urine volume, high urine calcium, low urine citrate. I think the one distinguishing factor is the urine pH. So high urine pH or alkaline urine is associated with increased risk of calcium phosphate stones. So this can occur in the setting of distal RTA, and then topiramate I mentioned before, causes the proximal and distal RTA. And so again, to prevent them, again, like any other kind of stone, you're going to tell the patient increase their fluid intake, increase urine volume, and then treat hypercalciuria, low sodium diet, low protein, thiazides, etc. And then correct hypocitraturia, so give potassium citrate if that's present. Although you have to be a little bit careful because potassium citrate will provide more citrate, but it will also increase the urine pH. So you kind of have to balance those two things. And then address the high pH. So if the patient has an RTA from some, addressable, correctable cause, then try to correct it. And I have in a few cases, a couple cases, I have recommended that patients on topiramate, stop it. Usually it's when patients are on it for seizure disorders. Unfortunately, there seem to be a lot of alternatives, so I haven't really had an issue, when I've suggested to patients that they talk to their neurologist about stopping it. And then uric acid stones, the crystals are rhomboid shaped. You can see some examples on the right. And I think one of the things, again, maybe board review or testing. So these uric acid stones, you remember, are radiolucent, meaning that they're not seen on X-ray. So again, if you want to prevent uric acid stones, you want to, did I skip a slide? So you want to increase the urine volume, so low urine pH is a risk factor for uric acid stones. So you want to, if the urine pH is very low, you want to alkalinize the urine with potassium citrate. And then another risk factor would be, high uric acid levels in the urine. So, like your gout patients, you're going to counsel them to, reduce dietary purine intake. And if it's really high and increasing the pH doesn't help, or, isn't sufficient, then you'd consider allopurinol. But that's usually sort of, not the first thing we go to. And so in terms of pH, so I think I mentioned higher pH, risk of calcium phosphate stones, lower pH, higher risk of uric acid stones. So you want to be somewhere in the middle. So between 5.5 and 6.5 is where we try to stay to reduce the risk of stones. And I should mention that calcium oxalate stones are not, pH does not affect, it's not a risk factor. All right, struvite stones, crystal, you have the coffin lid crystals, here's some, so nowadays, right, you're going to see fragments like this after some sort of lithotripsy. So this is a very older, picture when they used to do open, nephrolithotomies, and you sort of go in. I have, have a patient who has a, incision in his, back about, I don't know, maybe 8 to 10 inches where they literally, cut him open, to remove some stones. But this is, a struvite stone that is, removed nearly intact. And these are composed of magnesium, ammonium, and phosphate. And so prevention of struvite stones is challenging because the risk factors for struvite stones, are recurrent UTIs, neurogenic bladder. You have some sort of functional bladder issue, which can be hard to correct. You're gonna check sometimes. Stones, these struvite stones form in patients who have, calcium oxalate stone, some sort of calcium stone to begin with, that gets infected, and then that sort of leads to the development of a struvite stone. So if there is, if there is hypercalciuria, I would treat it, but really you can't, you really can't make headway, against these stones, and really, removal by, urology, is the key, because bacteria can survive within stones, and, you can give them tons of antibiotics, but it's hard to eradicate the stones. So ideally, you'd have urology go and remove all the stones, and then sort of increase fluid intake, address hypercalciuria or other risk factors, and sort of pray that, the stones don't come back. Okay, cystine stones. So, again, the hexagonal, I think classic crystals, they have a yellowish color. And they are also radiolucent. So pure cystine stones are radiolucent, but then a lot of cystine stones can contain some calcium, which makes them radio-opaque. But if they're pure, then they're also going to be radiolucent, like the uric acid stones. Okay, so risk factors. So who gets cystine stones? Patients with cystinuria. So cystinuria is an autosomal recessive condition resulting from mutations in this transporter, a basic amino acid transporter that's located in the proximal tubule, also in the small intestine as well. So it's characterized by urine cystine levels of over 400 milligrams a day compared to less than 40 milligrams in someone who doesn't have cystinuria. And so you can imagine that these patients are going to present early. They're going to have stones maybe before age 20. They're going to come to medical attention that way. And so what can you do? Again, increase fluid intake. You can increase pH. So cystine stones are much more soluble when the pH is high, so 7 or higher. And then also low reduction of sodium, dietary sodium also seems to reduce cystine stone formation, although I don't think it's known why that is, what the mechanism is. And then if conservative measures fail, then you use, there are a couple of drugs that are available, although they're not, they have a lot of side effects or not very well tolerated. Penicillamine and tiopronin are thiol-based drugs, and I'll show you on the next slide sort of how they work. And then captopril, if the above two, penicillamine and tiopronin, are not well tolerated, then captopril would be another alternative. But there's limited evidence, 3 times a day, hypotension, may not necessarily a great alternative, right? So you have cystine, you have these disulfide bonds, and so this complex, is insoluble. But if you add, so thiola is tiopronin, that has a sulfide and so you add that to the mix, and then you can have these, these disulfide complexes with cysteine and the drug, and that's actually more soluble. Oops, sorry, and I have some more pictures of some cystine stones. Okay, all right, so we talked about the different kinds of stones and risk factors and what to do about them, but let me sort of put it into context. So what, when do you do what? So, in terms of the evaluation, so if you see a patient, they have, maybe they got CT scans for something and you see a stone, you ask them, have you ever had, ma'am, sir, have you ever had, any problems with stones? And hey, no, I don't know what you're talking about. You really don't have to do anything. Unless it's, unless someone has a lot of stones or very large stone, but that's highly unlikely because people with large stone burden probably would have had some, symptoms in the past. So I'm talking about the people who have, incidental stones, on a CT scan or something like that. Those you don't have to do anything about. If you have a patient who has a single, symptomatic stone or symptomatic episode, so they passed a stone or maybe, they need to see a urologist. Of course, I'm going to do, I'm going to see them. I'm going to get some basic labs and a urinalysis. If there's concern for primary hyperparathyroidism, I would check PTH. Ideally, we'll have stone analysis so we know what we're dealing with, although that's not always available. And then typically, I'll review if there's any recent imaging, or if there hasn't been recent imaging, just get imaging just to get a sense of, what's the stone burden? Is it zero? Is it, a lot? Is it, somewhere in between? So, right, so in the acute setting, you're going to get a stone protocol CT. But if you're, so in the sort of monitoring, or, just to get a sense, assess the stone burden in someone who's not having any symptoms, there are a couple different options. So KUB, they're good for, measuring the size of the stone and, knowing where in the ureter it may be, but it's not very sensitive. So it detects 30 to 55% of stones seen on CT. So, but urologists tend to like this. So we all, I'm more comfortable with ultrasound because I order ultrasounds all the time, for my CKD patients. Urologists, tend to order more KUBs. And so you can, I think it's pretty, I don't think we need the arrow to show that, oh, there's a stone here. So this, again, just another reminder that, so there is a stone here, but you can't see it because it's a uric acid stone. So when they did an IVP and injected contrast, you can see that there's, a filling defect and that there's a stone there. Okay, ultrasound. The benefits of ultrasound, as you know, no radiation. You can detect hydronephrosis, although not as good as CT. Low to moderate sensitivity, compared to CT. It's not very good for measuring the size of stones or locating, in the ureter. And of course, patients who are obese, it may not be the best study. But if the stones are fairly large, you can see them pretty clearly. Small ones, they're kind of hard to see. But again, usually I'm, getting an ultrasound, annually just to compare sort of year after year. So, for me, typically I would use an ultrasound. CT has the highest diagnostic accuracy, or the accurate location, detects hydronephrosis. You can see very small stones that you can't see on ultrasound. But of course, it's radiation, so you might want to avoid in children and then pregnant women. But you can see, again, you don't really need the arrows to clearly see the stones that are present. Okay, and then, okay, so that gives you sort of a lay of the land. And then when do you do the litholink? When do you when do you subject the patients to the 24-hour urine profile to look for risk factors? So typically, I don't do it in everyone. It's people who are high risk or interested first-time stone formers. So I saw a patient, my previous job, who had a single stone, but then got septic, was in the hospital, so it was quite quite eventful, quite traumatic. So she was, I want to do everything I can to prevent having another stone. And then then people who anyone who's had 2 or more episodes, past stones or required urologic procedures, they should be getting further evaluation. So who's high risk? It's not anyone with a solitary kidney, right? They have more to lose from a stone. Family history of stone disease, malabsorption, recurrent UTIs, other predisposing conditions, or who are, or other, you can also define, figure out who's high risk based on a predictive model. It's called the ROCS nomogram. It's the population cohort study of stone formers in Olmsted County, Minnesota. And it's a prediction, it predicts the risk of a second symptomatic stone episode after, someone's presented with their first. So for example, so what you do is, you just go through, what's their age, what's their, gender, race, family history, et cetera, et cetera. And then, you add up all the points, and then depending on, and then you can, this line gives you the risk of having another stone episode in 2 years, 5 years, and 10 years. So you can see that it's very, it's very variable, right? So I think over 10 years, the risk of recurrent stone is 50%, but you have some people, you have some people whose risk is very low. They're they're unlikely to have a former stone. Then you have another stone, and then you have patients who are very high risk. So this I don't use this routinely. I kind of use this sort of gut check. So if I saw a patient for proteinuria, for something totally unrelated, proteinuria, but he'd had a history of stones and he'd seen a urologist who recommended he do a 24, metabolic evaluation, but he didn't do it. And so he was asking me, should I do it now? I was like, well, I sort of, my instinct was that, I think your risk is low, so I think we should focus on the proteinuria and not, we can address the stones at a different time. But I sort of just did this. I actually did, sort of on the e-visit with the patient there, just to confirm that my instinct was correct. And for the interest of time, I won't go through the example. Okay. And then once, right, so I do the 24-hour urine stone risk profile, I identify, hypocitraturia or hypercalciuria, and I do some, I recommend dietary changes, or maybe I prescribe a thiazide, or whatever the case may be. So after I make any change, I'll recommend another 24-hour stone risk profile in about 2 months, just to see how we're doing. And then once it's stable, once the risk factors look well controlled, right? The little graph, more dots on the green side of things than the red, and the patient's stable, then I'll recommend that they do 24-hour urine every 1 to 2 years, and then I usually get in imaging once a year just to assess, make sure that stone burden is not increased. Okay, so in summary, so stone disease is very common, and in the future, the prevalence is likely to increase. And there are no modifiable risk factors that can be addressed that may reduce stone risk. So I think what's nice about stone disease is that, patients are always asking me, what can I do to reduce my, reduce risk of progression of CKD? And I'm like, not much, but there are, several dietary modifications, as I've gone through, that patients can implement that that really can have a significant impact on their risk of stones. But the number one key is increasing the fluid intake, urine volume, which is easier for some folks than others. And then and that's holds true for any kind of stone disease. So even if you don't know what kind of stone the patient has, you're not going to be wrong if you tell them to drink more fluid. And then you want to it can't hurt, again, because calcium, 80+% of first stones are composed of calcium, right? It can't hurt. You're probably not wrong if you tell folks to reduce salt intake, animal protein intake. May be helpful for their blood pressure and for other other things you're managing them for as well. And then and then don't reduce dietary calcium, because that will increase oxalate in the urine. And then just a plug for so if you have a patient who's had recurrent stones, or lots of get a CT and there's lots of stones. If they're symptomatic, don't send them to me, send them to the urologist, right? Because I'm not going to be able to do anything about a stone that needs to be removed. But if if it's stable, or but you think they would benefit from counseling or further evaluation to try to reduce their risk of further developing those, I'm happy to see them. And some urologists, I think some urologists are happy just to do procedures and not do anything medical, but other urologists are very interested in stones, and so those patients, they will do everything I've described, and then probably refer them to us if the patient develops AKI and HCTZ, or something happens, or they're not straightforward, then they might end up with us. But you'll see, as you see patients, you'll see that sort of, sometimes the urologist is ordering the Litholink, the 24-hour urine, sometimes the nephrologist is.